Well, welcome to the Hopkins Business of Health Initiative webinar series, Conversations on the Business of Health. I'm Dan Polsky, director of this initiative. Our initiative brings together scholars from across the university who share a vision of a healthier America supported by an affordable and equitable high-value health system. In pursuit of this vision, our work focuses on the role of business and incentives through rigorous, objective, nonpartisan, interdisciplinary research. The role of business is often cast in political terms, but we are creating a space to seek a common ground from different perspectives. So let's turn to today's webinar, Delivering High-Value Employee Healthcare, How Businesses Can Do Better. So first, only ground rule here, we go to 1 o'clock, but for everyone in the audience, please feel free to use the Q&A function, and we'll do our best to respond to questions and leave some time at the end for that. So now I'm going to turn the proceedings over to our moderator, Joanne Kenen, a longtime health journalist who is now the Commonwealth Fund journalist in residence at the Johns Hopkins Bloomberg School of Public Health and a member of the Hopkins Business of Health Initiative. I'm turning it over to you, Joanne.
This is the first in a year-long series, so I'm honored to kick us off. We have two guests with us, Dan Mendelson, who's the CEO of Morgan Health, which is part of JPMorgan, and Elizabeth, I'm going to call it the Pacific Business Group of Health because I'm used to it, but Elizabeth Mitchell is the president and CEO of the Provider Business Group of Health. It tells you how long I've been covering healthcare that I still want to say Pacific, but you are now national, and we all know the drawbacks of Zoom, but the advantages are we get to have people from across the country without having to fly. So welcome to you both. I guess I wanted to start off, and for those of you in the audience, I'll work some of the questions in as they fit in our conversation, and we will leave time at the end to answer the stray ones or take on some of those. As Dan said, our task at our initiative is sort of, business is a huge player in healthcare, whether you are ideologically embracing or imposed, it is the reality. Employer-sponsored insurance did not go away when the Affordable Care began. In fact, that is still valued as a fringe benefit. It's still a really strong sector. Healthcare is expensive and healthcare remains problematic. So we're going to sort of talk about, starting with the employer-sponsored, what do the people who are paying the bills, the businesses, the employers, what are they doing? What can they doing? What changes are we seeing in terms of making this an affordable, workable system that improves our health and doesn't drive us crazy in the process? For quite a few years, there's been, forever, right? For many years, there's been talk about value. We don't all agree on what value is. And a lot of the time it was this big idea out there, but on the ground, what businesses were doing to save money was just to pass on cost shifting, right? Employers shifted costs to workers in the forms of higher premiums, and they shifted costs to workers in the higher co-pays, and out-of-pocket expenses, which could have very perverse incentives. Elizabeth, are we at the tipping point? Are we at a moment where people get value and have tools to pursue value in a way that they did not have before?
Well, hi, and thank you. I do have to make an important correction. We are not the Provider Business Group on Health.
Purchaser.
We are purchaser only, and I think that is actually critical to this conversation in this context.
You were correcting it, right?
We are a 501c3. We are a membership organization of jumbo employers and public purchasers as well. We've actually been around for about 33 years, so we have been looking at this question for quite some time. I would say value is absolutely going down. Costs are going up, quality isn't. So, that results in lower value. I will say without question, our members, we have about 40 members who are, as you mentioned, national, everything from Walmart to Microsoft to Salesforce and CalPERS and other public purchasers. They are actively engaging in what can they do to actually improve value. And I think it is true. There was a trend that maybe there was an easy-ish fix to this by having employees have more cost sharing, helping them become, quote unquote, active consumers. But that just doesn't work in healthcare. There's no information. They have no leverage. And I will we have noted that the research is showing that they're also avoiding or missing important preventive care. So our members, at least, who are somewhat self-selective, they're a very innovative, bold group of purchasers, are taking it upon themselves to do something about it. And unfortunately, the industry has consolidated, and it makes it even harder to make a dent on pricing or value. But they are absolutely saying, where the industry is not responding, they're going to take it on and do it themselves. One last point there. Jumbo employers for years relied on their brokers, their consultants, their health plans, their PBMs to get the best value for them. Purchasing healthcare is wildly complex, and it's not their day jobs. They build airplanes and computers, and yet they are expected to somehow fix US healthcare, and they relied on these partners. And I think what has become clear over the last few years is that they weren't necessarily working in their interest, that they're actually quite happy with the status quo, thank you very much. And it really is up to the self-insured employers, who are the only ones, other than Americans and their families, who have the incentive to reduce costs and improve quality. So that's where they're at. And I would say we are at a tipping point, because the industry has been unresponsive.
Dan, you went to Morgan just about a little over a year ago, right? In fact, we did an event just about a year ago. I remember exactly when it was. It seems to be a September tradition now. You have multiple goals there. You are trying to come up with a system that covers JPMorgan's employees in a value-driven, high-quality, and hopefully lower-cost way. You are also trying to use that as a jumping-off point for ways that those improvements can spread throughout American healthcare. You cannot undo the legacy of everything that you're in your year there. You're starting, I guess, with for your own employers, you're starting with partnering with a really good advanced primary care program practice that existed in was it Cincinnati?
Columbus.
Okay, Columbus.
You're close. You're in the right state, Joanne.
And then they love the right first letter. And I think you're covering, is it 30,000 of your employees?
We have 40,000 employees and dependents in Columbus. So
okay, and how many of them are shifted into this practice?
we'll see. We'll see.
So
yeah, it's really a pleasure to be here with you, Joanne, and Elizabeth. I love the way you queued up kind of the beginning of the program, and I'll say actually our goal is very simple, and it's one clear goal. Our mission is to drive innovation in employer-sponsored healthcare. That's what we do, and it's the way that we're oriented. We have various ways of doing that. We're focused on cost and on patient affordability and quality, which are kind of the goals that Elizabeth first laid out. And we're also focused on health equity, which is a third very clear and very important goal for us, and one that we are hoping to improve dramatically over the course of the next few years in ways that I will describe. But the goal is really one goal, and it's very clear. And we have various ways of doing that from JPMorgan Chase. We have, first of all, an allocation of $250 million from the JPMorgan Chase balance sheet to invest in companies that are catalysts for innovation nationally. And that's what we're doing. We've made 5 investments so far in the little over a year that we've been chartered. And the focus has been advanced primary care, accountable care navigation, and then we're also focused on moving care from expensive settings like inpatient clinics into the home. And that's kind of emblematic of our most recent investment, which is in home lab testing. And we're very excited about that, and I'm happy to talk about that more. But kind of the transactional part is a very important aspect of what we're doing. And then, as you correctly pointed out, we have 285,000 employees and dependents in the US and spend about $1.7 billion a year on healthcare. And our employees, as well as the 150 million employees nationally who get their care through their employer deserve better. And our goal is really to raise the bar. And look, there are places like Columbus, Ohio, as you mentioned before, where we're fielding a very innovative advanced primary care program where there really weren't alternatives. There were not accountable care alternatives there. And so in order for us to be able to offer that, we have to build it. But whenever we build something, it is never just for our employees. It is always scalable and intended for the marketplace. So everything that we're doing in Columbus is going to be available to other employers in Columbus. And in fact, I'll be in Columbus on Monday talking with a whole group of employers about what we're doing and inviting them to come in and share in what we're doing.
So talk about what that looks like. I mean, we'll come back to the investments you're making, but you're trying to get willingly, or not. Last time we spoke, this is a choice. The employees can choose this or stay with what they have, which may not be the best thing for them, but people often like what they have, right? Or they're change averse, or healthcare is complicated. I mean, it's a sticky. People don't always change if they don't have to. What is the vision? What attracted you about this particular practice, this large independent practice? You could have gone anywhere in the country. Why? And you have a lot of employees in other places too. You may have a particularly large concentration there, but you're a big company.
Yeah.
What they were already some way, a good way toward the vision you want to build out. So just say, go back to that practice. Why is Morgan Health in Columbus, Ohio?
Great question. So about half of our 285,000 employees and dependents are concentrated in 7 geographies. And in many of these geographies, we are a relatively large fish in a relatively small pond, and Columbus is one of those, where we're the largest commercial employer in the state. So we come in with some scale, and that's a good position to be in to create something new. Then, in addition, we have this wonderful advanced primary care practice, Central Ohio Primary Care, in Columbus. We've worked with them for many, many years. Our employees love them. About half of our employees that have a committed primary care relationship already have one with COPC. So it's just a great place for us to be. And they've been doing full risk accountable care for Medicare for many years as part of Agilon. And so, it's a confluence of events. We also had the opportunity to invest in Vera Whole Health, and Vera is the organization that has the relationship with COPC. So we have wonderful partners. There's a great management team there, and everything that we do is collaborative, and we're looking for great management teams to create this vision of accountable care that is practical and that we can actually implement. So why Columbus? It's scale, it's the presence of a great practice that's already there, and it all came together for us. But we will have an accountable care solution in all of our largest markets, in probably a couple of years. I mean, one thing that I have come to understand about changing employee benefits is that you do need to move deliberately. And we have a great benefits group within JPMC. We work very collaboratively with them. And we have to make sure that we're offering choice and offering a better solution for our employees, and making sure that we're doing that in a caring way that honors the decisions that they're making for themselves and their families.
Elizabeth, can you, the first time I heard the phrase advanced primary care, I misunderstood it. I thought it was for people with primary care for people with advanced illness, which was not a stupid thing to think, but it was wrong. Why don't you, it is something that you're working on and your members are concerned about. Why don't you just quickly define it for anyone who is thinking the same thing I thought? And how are they beginning to achieve it? I mean, here's JPMorgan Chase is a mega jumbo employer. They're doing it their way. You have other huge companies, including some like Walmart, that have really been associated with the push for better healthcare for many years, publicly committed and talking about it and trying things and sometimes failing and talking about that. So is this sort of like similar to the model that your members are looking for? This, really good practice that can provide this kind of care. So start with the definition, and where does something like this fit in with, or is it a unique thing that this company can do that won't apply to the other partners you have?
Oh, it's definitely not unique. And, our members are buying healthcare on behalf of, 21 million Americans. So they need these experiments to scale. And, what Dan mentioned about starting in a region where you have headcount is a, tried and true approach. We've done that for decades and it works. So as an example, about 10 years ago, we created a Centers of Excellence program for specialty care with Walmart, Lowe's, and McKesson. And as evidence grew over time that not only were outcomes better and experience was better, but also total cost came down, more and more employers joined in. So it sounds like that's the approach we're taking in, Dan's taking in Columbus, which makes sense. And our members are now putting those learnings to work to actually do a 2.0 version of this, as it were, to actually start with identifying advanced primary care practices in regions and in communities. Healthcare is notoriously bad at branding and marketing. Nobody knows what advanced primary care is. For us, what it means is it's whole person health, including mental health, including, health in the community, has to be equitable, accessible, and really focused on improving outcomes. None of that is rocket science. The evidence has existed for years on what actually does that, but unfortunately the system doesn't enable it. There are payment barriers, there are data sharing barriers. So our members have come together over the last 2 years trying to understand what they can do to make change. We don't have a $250 million check. We aren't VC investors, but we partner with practices and with many of these new private sector entrants like Vera, like Crossover, and others, and try to find the best practices in the community that meet employers' standards. So we have articulated what matters to jumbo purchasers and articulated the performance metrics they would like to see these practices achieve, because they want to know where to send their employees. One of our members just a couple of weeks ago said, we were in a meeting in Chicago, he goes, in 2 minutes, I can find the best deep dish pizza here. I have no idea how to find the best primary care or the best specialty practice. So we are helping them do that. And then we're helping them make sure that their employees access those practices and use that, because there is data out there that shows employees with a primary care relationship cost 30% less than those that don't. That's just, but more importantly for our members, their health is better, their outcomes are better, they are just healthier. So that is a win-win. If they can get them attached to a primary care practice and then using only the highest quality specialty practices, they know that that's better care at lower cost. So we are working very actively with multiple partners to try to make this happen across the country.
I mean, there's no healthcare entity that sells itself as worse care for higher cost, right? I mean, the reality is that might be what they're offering, but they don't admit it. As a journalist, I can't tell you how deluged I get with emails from companies with data solutions, right? I mean, just I hadn't turned it off, lots. Mm-hmm. How good are the tools? Like when you and where are we in being able to say, okay, I can do the equivalent of the pizza now, right? I can now that we have enough data, we know how to crunch it, we know how to match it up with the company's workforce needs, because they're going to be somewhat different populations. Like, what can you know as opposed to the guesswork of 10 years ago? Yeah. I'm assuming it's a lot better. Let me start with Elizabeth, then come back to you, Dan.
Yeah, first of all, this is not a technology problem. There is technology out there that could do this. This is a business model problem because hospitals, health plans, others don't want to share their data. And we've got data systems that don't talk to each other by design so that they maintain sort of their proprietary special, whatever, that but it's not in the interest of patients, and it's not in the interest of families who are trying to find the best care. So accessing information on US healthcare quality and cost is notoriously difficult, but not because the technology doesn't exist. So we are trying to take on some of those barriers, through better contracting or through direct partnerships with providers who will share their information. And we are in California, we recently got several health plans to agree to use a common set of performance measures so they can share data and stop driving practices crazy with every health plan wanting different information. So these are sort of systemic changes that I believe will take collective action to change, but it is very doable.
Okay, Dan.
Dan thinks about that.
Yeah, look, I'd say, Joanne, that the answer to your question is in performance metrics and in aligning financial incentives for providers and payers to the financial, to the really the objectives and the needs of our patients. Okay, and so that's the framework, if you will. And I'd say that in our experience, there are some systems that are better at doing that than others. So, for example, an example of a great environment, a very data-rich environment, is Kaiser. We recently opened up our enrollment for our employees in California to Kaiser, and they've been phenomenal at giving us dashboards, giving us information, helping us understand clinical information that goes well beyond what is typically on the claims data. And as a result, we're now in some very advanced discussions with their senior management team about taking performance risk for improvements in health equity. That's the kind of thing that we want and we need, and that's where we are going as a purchaser. And there will come a point at which we won't contract with organizations, providers, payers who can't do this and can't improve the health of our populations and prove it. And so Kaiser's a great example of a system that's further along. What we're architecting with Vera right now is another example of a place where it's a data-rich environment. And one of the reasons why we feel like we need to engage directly and create these new models is that we don't see these models everywhere. A lot of the geographies where we're operating right now, it's claims data, and the claims data come in really slowly. And we don't have good tools to kind of make the claims data usable, and we don't have the systems to align the incentives of the providers. So we're going to go geography by geography and get these systems aligned. And I'd say one other thing, which is that we have every hope and expectation that the large carriers will evolve over this period of time, and we want to see that. We want to support them. We will support them. We would love to see the large carriers come to the table with more meaningful, accountable care products. They're just not there yet right now. And, I'll say that much as we would love to have the luxury of not worrying about healthcare, we don't have that luxury. And so that's why we've chosen to be the catalyst here to kind of, get involved and to help make these new systems available to employers in the US.
Primary care, both of you in our prior conversations and the work you do really emphasize the importance of primary care because, it's not exactly America's strong point, and it's sort of the root of, I think the three of us all say it's that failure to invest properly in primary care, to emphasize primary care, to give it the respect it's due, is the root of many of our problems. But it also can't fix everything. You can have the world's best primary care doctor, and you can still get really sick. Elizabeth, you talked about centers of excellence, places that people, is there an emerging model that is dominant, or just various businesses find the place that you're building the primary care system, and then you have contractual relationships or partnerships with the best oncology center, the best spine surgery when it is truly needed, or something like, expand on that a little bit. And then, Dan, we've been talking about primary care in Ohio. Talk about what happens when, you don't need primary, you need the specialist, you need the surgeon, you need the whatever other service. You mentioned Elizabeth before, but talk a little bit about what patterns you're seeing, what models are emerging, because the idea of a center of excellence is not new, but how is it maturing, I guess, is the question.
Well, I can just speak for our membership, and their interest is in finding regional centers of excellence. And we had great success. Our members had great success. Walmart is really a case study in this, in identifying centers of excellence nationally and sending their employees there. I think that remains a very important option, particularly for things like, transplants or very significant procedures that really should not be done, everywhere necessarily. And what we are now looking at is, how do you expand that to more specialties like maternity care? Oncology is something that can be done sort of with consultation from a center of excellence regionally, and really connect it to primary care, because effective primary care does share decision making. They make sure that the patient actually wants and needs this procedure. That appropriateness screening with the patient is actually one of the secrets to getting this right, because there is ample evidence that many procedures and surgeries are not even necessary. Imagine going for an unnecessary surgery because there is a financial incentive for you to have that surgery. So if you have the information, the time, the payment models that allow you to really evaluate what is in the best interest in the patient, you see reduced number of surgeries. And then when you actually refer based on quality, not based on contractual relationships, you get to the right care for each patient. And again, we have decades of evidence that show that you get better outcomes, better experience, and lower costs, and it's better for the patient. So we are looking to move this regionally to identify the best specialists, and then help the primary care practice know who those specialists are, because they don't have that visibility. They often don't have the data to even know what the relative cost or quality is of whoever they're referring to. So we're working on assisting them in that. And we're, as Dan is, we are starting in different regions, and look to scale as we learn.
Dan, what's the model for Columbus?
Yeah, I agree with what Elizabeth said. And the only thing I'd really add, so when we took a step back and said, kind of where do we want to focus our energies, because time is limited and resources are limited, and you want to make sure that you're kind of applying your energy to make something happen, we decided very consciously to focus on systems of care, as opposed to point solutions that might be in kind of one area or another. And so everything that we're doing right now is really focused on designing systems of care that will work. So I described Vera. Another investment that we made is in a company called Centivo. That's a wonderful company that focuses on the middle market. It's a company that focuses a lot on affordability. So they come in and negotiate contracts with a limited set of providers in a particular market, and are able to drive cost savings of up to 30%. And then they also have very good systems of focus on quality and equity that get layered in there as well. So those are the kinds of things that, and I'll say one other thing, which is that while we've made investments and we've chosen various accountable care providers for certain geographies that will suit our needs, we really want to see the whole market thrive. And our goal is not to, pick a winner, if you will. Our goal is to make sure that we are, kind of the catalyst in supporting a lot of these efforts nationally, so that all employers can more broadly access these systems of care, and ultimately affect the care of 150 million people nationally. So I'd say that with respect to the specifics, yes, it goes well beyond that the work that we're doing and the work that Elizabeth is doing with her membership does go well beyond just primary care. It has to. So I think about primary care and then digital engagement as being kind of a second thing. And when we survey our employees, particularly those under the age of 40, have a very core expectation that there's going to be outstanding digital functionality, not only with respect to visiting providers, doctors, nurses, pharmacists, others, but also with respect to being able to have choice models that are kind of layered in there. We think that artificial intelligence has a lot of potential to better patient selection of providers that are appropriate for them. particularly encompassing patient preferences. So that's an area that we're very focused on. And then yes, with respect to significant surgeries and episodes of care that are more significant, with respect to patient health, we also do believe that having centers of excellence, can be very valuable. So it's really all different aspects of care that we're focused on. And this is, by the way, one of the reasons why we want to work with great management teams that are doing this today, and so it's really, you have to engage. It's not like any employer, whether it be JPMorgan Chase or anyone, can go out and create these models by themselves. It's just not really a feasible thing. So this is a team sport.
So can I just pile on really quickly? Because I think it's great that Morgan Health is investing in some of these new companies, because it is very hard to get a foothold against the incumbents. And there needs to be some innovation and some catalyzing of these new approaches. And I think that is a really important contribution, because companies like Centivo and Vera, they're doing really good things, but they're taking on some big players. And
That's right.
That's actually one of the reasons we're hoping some of our members can put their heft behind some of these new models too, because it's going to take a lot. And we actually had a summit in Chicago a couple of weeks ago, and Centivo was there, and Vera and Crossover and One Medical and Aledade, and they're all ready for change. They want to practice differently. They want to offer new options, and yet it is very hard to break through the status quo. And so that, I think there's just huge opportunity, and that goes back to your initial question: are we at a tipping point? I think we are.
How much, this thing that you and I talked about when we had the prep call, you're working with jumbo employers. Dan just talked about trying to create an infrastructure for the middle market.
Yeah.
You don't have to be a jumbo. You're trying to create, I don't even like the word infrastructure, like a climate, like a stuff that works, like new for healthcare, right? That will create a new environment for purchasers and patients. Yeah. What about do you see that as accessible to the middle market, Elizabeth? And also, what about the small businesses? Because when we talked in advance, you were very worried about, there are innovations, there are opportunities, but it is a significant part of the market. They don't have economy of scale. They have, one very seriously ill employee can, one premature baby can, send everybody's premiums, in a small business that their risk isn't balanced out the same way. Are they 10 years behind? I don't want to pull out a number. I don't want to make you do that, but where are they in this process? Can they access what the jumbos are beginning to access?
Well, I run a small business. My brothers run a small business, and, they're seeing like 10 to 40% premium increases. They are desperate for change. They don't have the leverage. I can tell you, if the big health plans don't listen to my members, they're certainly not going to listen to a small employer. And our hope is that the changes that we can catalyze in the system, like better access to better primary care and more focus on quality and affordability and equity, we hope that benefits them. But we cannot do that first and foremost, because it's hard enough getting, a bunch of jumbo employers to go in the same direction. Yeah. But we are absolutely doing it with our mission in mind, that this makes the system better for everybody.
So I'm going to give a different answer to the same question, if I could, which is that this is what Centivo does, and this is why we invested in Centivo. Centivo comes in and for mid-size and smaller employers offers a product that is 30% less expensive than what they can get from the standard carriers, because it has a narrower network, but it also has a lot of very positive features with respect to advanced primary care, digital care, centers of excellence, and the like. So for example, in Dallas, they partner with Baylor, which is an outstanding system, and they offer that product for 30% less. And I'll say that there's one thing about the economy right now that is going to start to drive smaller employers to deal with this, because there's a tremendous amount of inflation in the system. It's coming to healthcare. These smaller employers will not be able to and cannot afford the kind of cost increase that is coming down the pike. And so it's Centivo and Crossover and Eden and Firefly and a lot of these products that are in market. And this is why I think it's really that Elizabeth is right, that we are at a tipping point right now, because it's not only just the demand for a better product, it's also going to be the cost imperative that pushes through with this inflationary environment that we have over the next couple of years. And I'll say, kind of one other thing, which is that that we need to support this environment so that there is a high level of choice. And it's not only groups like Elizabeth's and mine, it's also the policy context. And you don't see a lot of focus right now in the policy environment on anything other than Medicare, Medicaid, and the exchanges. And it is going to be very important, I think, for policymakers to also be supporting this kind of innovation. And one way that the federal government, states, and municipalities can be supporting this kind of activity is simply to offer an accountable care solution to their own employees. So we'd love to see. So we're in right now working in the state of North Carolina with Vera, and they're very interested in fielding this model to kind of engage more competitiveness in that market. And we'd love to be working with more states, municipalities, and with the federal government with federal employee health benefits programs to really engage and to help kind of fuel this market, because that is something that government can do at this point.
That was sort of like reading my mind, because the next question I was going to ask Elizabeth is, you work with these jumbo employers, and they include some public sector payers. Mm-hmm. So are the public members, your public partners, do they have the same concerns and approaches as a Walmart and a Microsoft, or how much conversion versus different needs are you seeing? I'm imagining it's a fair amount of conversion, or they wouldn't be both under your roof, but just take that on, because Dan also, state health plans could drive a lot of change in this country if they did it right.
Well, and I would say they have, and they are. I worked in Maine years ago, and the state employees were the most progressive purchasers. And Washington Healthcare Authority, CalPERS, there is a lot of innovation coming from state purchasers. And frankly, often they are even more cost conscious and more ready to do something different. They operate in different environments, the regulatory environment. I'm a former legislator. I apologize in advance, but they've got their legislatures coming in and say, do this. Sometimes it makes sense. A lot of times it doesn't. So they have a different context in which they're operating, but we are very clear. Our goals of flat trend by investing in quality, improving whole person health, and eliminating disparities, they're all in on that. So we have a lot in common, a lot we can and are doing together. But the policy piece of this, which I'm really glad Dan brought up, is really important, because private purchasers, the commercial sector, is 100% of the health system's profit, right? They're not all the patients, but they're all of the profit. So we have a lot of opportunity to use our sort of leverage to make the system more accountable. And policymakers haven't always understood that. We have been very active on the policy front. We're very active in the surprise billing legislation, in, the transparency rules for hospitals and health plans that just came through. We were very active in the attempt to get drug pricing extended to the commercial market. We didn't quite get there, but there's still benefit. Policymakers need to understand how that is affecting U.S. businesses. This is an economic development strategy to actually help businesses reduce their healthcare costs and invest it into jobs, into innovation, into expansion and growth. So there is a key policy component. One last thing, and I'll get off the soapbox, but I think this is why they created CMMI. They were supposed to be innovating. I spent a lot of time with CMMI on the land, on all sorts of things, PTAC. They have not realized that opportunity to create innovative new models. I'm still hopeful, but we need that innovation across sectors to really drive change.
Dan, are you as negative about where CMMI is after 10 years? ACOs are CMMI.
No, look, I have a different perspective on CMMI. I understand Elizabeth's, approach on this. I truly appreciate what CMMI has done in the Medicare context, because we're using that as an analogy over into the private sector. And, we couldn't be doing what we are doing in Ohio right now without the work that CMMI, as well as Medicare Advantage plans, have done. And so, I look at the extent of value-based care in Medicare and Medicaid right now, which has far outstripped the private sector. And we're really focused on kind of bringing in those models. And in fact, we have a number of really outstanding staff who came out of CMMI. And so we're using that knowledge base as well. And so we're kind of drafting on the knowledge base. But look, with respect to the policy agenda, I agree with Elizabeth that, historically, the policy agenda around employers was really focused on maintaining tax deductibility, keeping the government out of the ERISA bucket, and there's kind of a lot of stuff that traditionally, but it needs to shift now. It needs to shift towards bringing all of that accountability that is really being deployed in Medicare and Medicaid over into the private sector and supporting those efforts to kind of bring those ideas over. I think that we also need a more proactive agenda around data. And making data more accessible to consumers as well as to employers and others in a secure and validated way, so that we can really be innovating more on those data. It's a lot easier to get Medicare and Medicaid data than it is to be able to get even claims data. And employers have to struggle to actually get that. And if you're a patient, just forget about it. And so there's this whole idea somehow that patients own their own medical record. But what is that ownership if you can't actually get it? We've all had experiences of actually trying to get information out of the system for ourselves and our loved ones. And Elizabeth is exactly right. The providers have not taken seriously their obligation to make that information readily accessible to consumers. And I think that's a real problem that reverberates really through the system and makes it more difficult for everyone to operate. There are a couple of foundations that have really been very, very focused on this and instrumental. So the Arnold Foundation, we've had some great conversations with them. And I think that they're very interested and very kind of engaged on both the cost and the quality side. Peterson Foundation as well. We'd love to see more foundations getting involved in supporting bringing some of these value concepts over into the private sector, because the system will not change without bringing the private sector along. Not only the large employers, but also small and mid-size. And what we're doing in the exchanges, I think, is kind of another aspect, to the extent that you have smaller employers who kind of aren't engaged. And I'll say kind of one last thing on this. With respect, and Elizabeth is right, when you're small, so I also had the experience of being a very small company when I founded Avalier, and we were 10 employees, and then we were 20, and then we were 50, and kind of dealing with the insurance issues all along the way. The small employers do not need a changed environment. They need a commercial alternative that they can just go out and buy, that is tested, validated, really strong from a quality perspective, and addresses the needs of their employees. And so that's why we are focused on nurturing companies like Centivo, because they're the ones who are going to come to market with those kinds of products that are less expensive and really responsive to the needs of the employees.
If I'm a small business and wants that, something, either Centivo or something similar, how uniformly available is it across the country, or is it in pockets that are relatively sophisticated markets?
These products are now largely available. Centivo, Firefly, Eden is another, but employers have to go out and look for them. And this actually goes back to one of the—
they're there? I mean,
to
like a normal, quote, normal small business know it even exists, or do they think it's like I call my broker that I've been calling for the last 40 years? And
this goes back to the problem that Elizabeth mentioned at the very beginning, which is that the benefits consultants who are in there today do not have right now an incentive to promote these products. And that's another thing that candidly we're working on right now is, making sure that they get paid when they promote these products. But if you're trying to actually reduce the cost of the employer, paying another 10 or 15 or 20% to the broker doesn't really help. So that's something that you kind of have to navigate.
I'm going to go through a couple of the questions. I probably won't get to all of them. Some of them I've already worked in. I want to end though, and do a couple of questions. Let's do them pretty quickly. And then Dan, in an op-ed you wrote that was really a really smart observation that I want both of you to. That's how I want to end up. We'll come back. We'll do some questions. We're going to come back to this question. We're talking about employer-sponsored care. We're talking about care, coverage and care access through work. We are now in a world where work looks really different than it did in 2020. We are working in different places. We are digital nomading. We are, spending. I mean, I'm calling you from my mom's house today, right? We are. It's different, and it's going to stay different, and we don't know exactly. And telemedicine is not as simple as just the word telemedicine is not the answer to that. So let's come back to thinking about what does employer-sponsored insurance or healthcare look like in a different employment world. But some of these questions are more technical than others. Some of them I've already asked you. Let me get in a couple of them, and then we'll talk about sort of the are benefit consultants working against value-based care because of their actually receiving so much money from the insurers themselves? Who wants to take that, or both of you?
Well, I will say they are quite comfortable with the status quo. They are paid well. I think obviously consultants vary, as do brokers, but right now the incentives are conflicted. And I think we need to address that directly.
I once wrote a magazine piece that there are too many people trying to fix healthcare. There are a lot of them, right? Dan.
I agree. I agree with what Elizabeth said. I'd kind of go even a step further, which is that I would love to see the benefits teams of the largest corporations in America be aligned with quality improvement and the kinds of things that patients care about. So let's pay our HR professionals more when we improve diabetes, care for high blood pressure better, increase mammographic screening. It's like we all need to be participating in this. And by the way, my team also carries a whole set of incentives around quality improvement. And I would love to see every major benefits organization in the country do the same thing.
Can I just pile on a little bit too? I mean, I couldn't agree more. And, the benefits teams in these, even though they're very large corporations, the benefit teams are often small. And as healthcare has become more and more of a strategic priority, look at the Great Resignation. They are strategically committed to making sure their employees are healthy, happy, and that they stay. So this is elevating as a strategic priority. The Consolidated Appropriations Act of 2021 makes self-insured employers fiduciaries for purchasing healthcare. So this is going to be elevated appropriately so, in my view. And to Dan's point, we need to give them the tools, the resources, the teams they need to take on this really big and intractable problem. So, and your other point, work is changing. They're on the front lines of that. What are their work from home policies? The benefits professionals have had a lot on their plates, and taking on healthcare requires, I believe, more resources.
I have a question here from ACO skeptic, Dan. Medicare's experience seems to be that the savings are disputable in part because of the benchmark gaming noted by MedPAC. Why should employers invest? I mean, both of you are clearly answer it.
Look, I'd say we see substantial improvements in quality associated with the companies that we have invested in. With Vera, Centivo, we're engaged right now with Firefly. We see the data on employer populations. And so, look, I think that there has been a mixed experience in Medicare when you look back at kind of the data. So it's incumbent on us to figure out what works for our populations and deploy that. We cannot rest. I mean, it is not a world where we can say, hey, this isn't working. I think that from our perspective, we see the improvement. We know that it's out there. We know we can reduce costs. We know we can improve quality by aligning the incentives, and that's where we're going.
Okay, Elizabeth, do you want to add to that, or pretty much?
I concur. I do want to go on record saying I think the people at CMMI are really smart. It is a super brain trust. They have been up against a lot of barriers like OMB in getting some of these new models out there. But I agree. We can't stop. We just have to, build on the learnings and go.
And there's been a bit of a reassessment within CMMI now too, that, they've been throwing things at the for 10 years, which is what they were designed to do. And now it's a time to figure out.
I mean, you can't, it's an organization that is dedicated to rapid learning. And from my perspective, I appreciate what Liz Fowler is doing over there and what the team is doing over there. We appreciate them every single day. And we are building on their successes and also learning from the places where they failed. And failure is really valuable for learning. And if, it's like if you can learn from other people's mistakes, that's even more valuable than learning from your own, And so it's like, we'll take that and appreciate it every single day of the week.
I'm going to take this question and make it a little broader because this was asked about pediatrics specifically, but it's really not only about kids. There are programs around the country now that are working on greater alignment, coordination, communication. You mentioned North Carolina is one of the places where it stands out between the traditional medical and the social services, that they're not, you cannot address equity, disparities, and all sorts of other unmet needs without busting some silos. Payment incentives, it's all screwed up. It's hard to do. Someone told me the only way to get at this right is to start the committee, the congressional committee structure all over again, because that's where the silos come from. Are you doing this we are seeing some Medicaid and some state activity. How much are the providers you're working with or plans you're working with see this as part of their solution?
I'm really glad you raised this question. We've done a lot of work around this, and we did a study that we funded with NORC, which was a baselining study focused on health equity and kind of various aspects of social determinants that we published last month that I think is really important. And one of the things that I have found going out and speaking with CEOs of corporations that are self-insured is that many of them believe that health equity, as well as some of these social determinants issues, are Medicaid issues. And it's just not the case. And we all have to acknowledge that we have substantial health equity issues that we own as employers, and it's our obligation to make progress on them. They're very multifaceted. So, I talked before about performance guarantees and getting the incentives aligned. That is one aspect of it. Another aspect is transportation. Another aspect is what zip code a person lives in. Another aspect is that for one of the findings of the study that we released with NORC showed that C-section rates among Black populations are so much higher than white populations, even in the insured world, where you have kind of an insurance product that is being shared by all. So how do we address that? Are we actually noticing our employees who are at risk for a C-section, who shouldn't have one, kind of what their situation is? And so I think it's really incumbent for us to deal with this. We have food insecurity in the Fortune 100 companies that we also have to deal with. And so it's really all of these issues are the issues that self-insured employers need to tackle over the coming years.
And as you alluded, Dan, we're the inflationary era we're in is going to aggravate some of which were problems we hadn't addressed. Some of them were problems we made progress, and they're getting worse again. So, the next few years could be quite difficult. What are you seeing, Elizabeth? Is this something that's recognized in the ESI world, or people sort of think, well, that's Medicaid's problem?
Not at all. I will say, other than mental health, it is the top priority for our members, and they recognize they need to address it. They'll have employees sleeping in their cars, or they, need food or transportation. This is a problem for all of us. So, we're trying to find ways we can make a meaningful difference. We are working right now on how to address maternal health equity. To your point, Dan, it's shameful right now in this country. But we face these barriers where, health plans won't even collect or share race, ethnicity, and language data. How do you even know where your problems are? So there are a lot of barriers, but there is also, I would say, equal commitment to addressing them because employers recognize this as their obligation.
We only have a couple of minutes left, so let's go back to the new workplace. Like if you're working at home down the street from your office, that your healthcare really doesn't have to change, but that's really not the case for many people. There are people who are telecommuting from across the country. There are people who, young people who go to a different Airbnb in a different state or beach every single month, right? What beyond telemedicine? If you're small, if you're in a geographic area, how do you meet the needs of people who are, in a way different time zone, maybe a different continent? Anyway,
Look, I think
they're not all going to be in Columbus.
Look, a lot of the work is actually on site. I mean, in Columbus, we have call centers and data centers. We have data centers in Arizona. I mean, a lot of the work is on site, and so we are committed to having on site and near site clinics. We're very committed to having kind of a strong digital health front end, and we're committed to having kind of a high level of flexibility. People access care locally. So one of the things that I think we've come to understand is that if you spend too much time trying to drive national consistency, you lose out on the idea that healthcare really is local and that you're ultimately working with a provider in your own geography. So we're not losing sight of that.
Yeah, I'll just add, I mean, we've got to think out of this box. Telehealth is a really important new option, but guess what? We have policy barriers that even allow people to access care across state lines. We got to just realize, what decade we're in, and have our policies enable the care that people are trying to access. We also have to think differently about where they get care. Walmart has clinics where you go in for $4, you get a treatment. We can think about new partnerships, whether it's schools or communities or just whole new ways of thinking about health. And I think it will challenge the incumbents, and yet that's what we have to do because it's the system right now is not working.
Okay. And what is the one thing that that you think one thing that you think, just really quickly, because we have one more minute and I have to tell you what's coming next, that you're excited about? Like, I get really depressed when I look at a lot of things in healthcare, and like one thing that you think is about to burst open in a good way.
Well, I'll go. I am actually really excited because I am seeing the commitment and the courage right now to take on things that have just felt impossible. And it's among providers and purchasers and other partners. So I actually think that the pressure we're under right now is leading to renewed commitment.
Yeah, and we're in the same place. I mean, we have a phenomenal team at Morgan Health, and the team is incredibly energized. We're getting really outstanding support from the bank and nationally, and from the portfolio companies that we've invested in. And we're very energized to be working with Elizabeth and others to tackle these issues.
Yeah, and we're working together in new ways, and it's going to take all of us.
It'll be really interesting to see where I think there is just so much has changed in our healthcare system. There's a whole bunch of new problems, and there's a whole lot of old problems. And I think the next year or so could actually be maybe
good year
where some of the brick walls that have been there for years and years may end up having a little Harry Potter brick you can open and get through. Okay, thank you for joining us today. As Dan told you at the beginning, it's the beginning of a series we're doing at the initiative, and the next one is October 14th. It's called "Whose Business is Health? Corporate Social Responsibility and the Health of Americans." They will almost always be at noon on Fridays, and you will get reminded to join us and register for that one as well. Thanks for helping us start, and that's it for today.
Thank you, Joanne.
Thank you. Thank you, Dan. See ya.